training. The first half of the Let's Learn Medicare Medicare Basics overview will go up to slide 45, and then tomorrow we'll continue on the training. So again, it won't be a full 2 hours, which I know is definitely a lot to ask of everybody. So let me see. Okay, and everybody's seeing the learning objectives right now on their screen?
Yes, everyone's
Okay,
saying yes.
great. So again, it's going to be a pretty comprehensive overview of Medicare. We're going to start with the Medicare basics, the eligibility, enrollment, coverage and costs, Medicare Part D, what Medigafs are, the Medicare Advantage plans, and we'll also be talking about Medicare and COVID-19 and some of the changes to Medicare coverage that COVID-19 has brought, at least on a temporary basis. So we'll be covering that whole section today. And tomorrow we'll go into the coordination of benefits in Medicare, as well as the low income benefits. So Medicare basics. What is Medicare? Medicare is a federal program that provides health insurance for those who are 65 or older, and those who are under the age of 65 and have been approved for Social Security Disability Insurance, or SSDI, for a certain amount of time, specifically for 2 years. So if they're under 65 and they're collecting, and they have collected SSDI for 24 consecutive months, then they also are eligible for Medicare. There's no income requirements. It's really just the eligibility criteria that I mentioned, either have aged into Medicare, meaning they're 65 years or older, or if they're under 65, have collected SSDI for 2 years. Now, when somebody's eligible for Medicare, there are two primary ways that they could get Medicare coverage, or they could get Medicare administered. One is Original Medicare, and this is a traditional program offered directly through the federal government. But the other way is also through a Medicare Advantage plan. And this is Medicare coverage that is provided by private health companies that contract with Medicare. So they're still part of the Medicare program. It's just that it's a private health company that's contracted with the federal government to administer Medicare on behalf of those Medicare beneficiaries. So as I mentioned, one of the primary ways of becoming eligible for Medicare is through age, meaning that somebody turns 65, they're eligible for Medicare if they turn 65 and collect or qualify to collect Social Security or railroad retirement benefits, or are a current U.S. resident and either a U.S. citizen or a permanent resident, having lived in the United States for 5 years in a row before applying for Medicare. So again, there's really no income requirements. A person can become eligible for Medicare if they're 65, they're either a U.S. citizen, or have legally resided here in the United States for 5 continuous years. Person is under 65, they could become eligible for Medicare if they have collected 24 consecutive months of Social Security disability insurance. If they have ALS, if they've been diagnosed with what's called Lou Gehrig's disease, there is no waiting period, and they're eligible for Medicare when they start receiving their SSDI. So at the very beginning of their SSDI payments, they'll get Medicare for ALS beneficiaries. Or if they have end-stage renal disease, they're under 65, they could also enroll into Medicare. End-stage renal disease Medicare, or ESRD Medicare, really is its own little world in Medicare. There are many different avenues into Medicare. If somebody has been diagnosed with ESRD, it could be based on the time that they've been on dialysis, or based on the time that they received a kidney transplant. So it's its own little world. We could spend pretty much the whole day talking about ESRD Medicare, but I do just want to bring that to your attention, that folks who have been diagnosed with end-stage renal disease can also get Medicare in a variety of ways. So Medicare is broken up into a bit of an alphabet soup. There's different parts of Medicare. Part A is hospital or inpatient benefits. The key word there is inpatient, meaning that if somebody's at the hospital and they've been admitted as an inpatient, then that's when Part A will start covering their services. If they're at the hospital and they have not yet been admitted as an inpatient, then Part A is not really covering any other services. Part B is what covers outpatient benefits and also covers general doctor's visits. Part D is the newest part of Medicare. It was actually introduced in 2006, and it is the prescription drug benefit. Original Medicare includes Parts A and Part B, and the original Medicare coverage is denoted by that original Medicare red, white, and blue card. And if you know anything about that card or you've seen that card, you see that there's only room for A and B. So original Medicare only covers A and B. Anybody in original Medicare, if they want Part D, will have to enroll into a standalone Part D plan, and all standalone Part D plans are administered by a private health company. So what happened to Part C? So Part C is not really a different part of Medicare. It's just a different way of getting Medicare. And that's what I had mentioned about having a different way of getting your Medicare administered, and that's through the Medicare Advantage option. So Part C is really the Medicare Advantage option. So there are 4 ways to enroll into Medicare. Automatic enrollment is the I guess the most straightforward path into Medicare. Automatic enrollment occurs when somebody has been getting a Social Security benefit and then becomes eligible for Medicare. So let's say if somebody is started to collect their Social Security retirement benefits at an early age, maybe they started to collect it at 62 or 63. Well, because they're collecting that retirement benefit from Social Security already, Social Security will automatically enroll them into Medicare once they turn 65. Same applies to folks who are on SSDI, Social Security Disability Insurance. Once they have reached that 24-month of consecutive SSDI payments, Social Security will automatically enroll that person into Medicare. So those are how automatic enrollments into Medicare works. Somebody has to be actually collecting a Social Security benefit prior to becoming eligible for Medicare in order for automatic enrollment to work. The initial enrollment period, and we'll talk about that in the next slide. The initial enrollment period is to be used for somebody who is not going to be automatically enrolled, meaning somebody who is not yet collecting their Social Security benefits. They would want to enroll into Medicare during their initial enrollment period. That is the initial window for folks to enroll into Medicare. Missing the IEP means that they may face consequences into getting Medicare at a later point in time. If folks miss the IEP, then they also have the general enrollment period and the special enrollment period to enroll into Medicare. And we'll talk about those in the next few slides. So initial enrollment period is a 7-month period, including the 3 months before a person's 65th birthday month and the 3 months after a person's 65th birthday month. So again, it begins 3 months before somebody's 65th birthday month. So usually it is very, very strongly advised for folks to enroll into Medicare during those 3 months prior to their 65th birthday month. And that's because if they do that, then their Medicare effective date will be the first of their 65th birthday month. That's strongly advisable. It will prevent any gaps in coverage. It will confirm that they will have Medicare as soon as they enter their 65th birthday month. Enrolling into Medicare within the 65th birthday month means that their Medicare effective date will be the first of the following month. Enrolling in any of the 3 months after their 65th birthday month usually means that there's a 2 to 3 month gap before that Medicare becomes effective. So that is why it's very strongly urged for Medicare beneficiaries to enroll during their 3 months prior to their 65th birthday month to ensure that their Medicare becomes effective as soon as they turn 65. So if somebody misses their IEP, again, the IEP is the initial enrollment period, so that's the initial window to enroll. If they miss the IEP, then there's a few ways that they could get Medicare depending on their circumstances. If they missed their IEP and they didn't have an argument to access the special enrollment period, meaning that they weren't actively employed during the time that they became Medicare eligible and they weren't covered by their employer group health plan, then they would have to enroll into Medicare during what's called the general enrollment period, the GEP. It's an annual enrollment period, runs every year from January 1st through March 31st. And this is an avenue to enroll into Medicare, usually Part B, because most people will enroll into Part A as soon as they become Medicare eligible, because Part A is premium free. So usually you'll see folks using the GEP who enrolled into A but didn't enroll into B because Part B carries a monthly premium to it. Enrolling during the GEP, however, will likely mean that they will have a considerable gap before their Medicare effective date. So their Medicare effective date will be July 1st. During in the year that they enrolled into the GEP. So if they enroll on January 1st for Part B because they didn't enroll into Part B when they were first eligible to enroll into Part B, then that means that they have to wait until July 1st of that same year before their Part B becomes effective. And also, they may likely also be subject to a Part B late enrollment penalty. So we'll talk more specifics about the GEP at one of our trainings tomorrow that I'll be providing, and that's the maximizing access to Medicare training, which will be at 2 p.m. tomorrow. The special enrollment period is provided to folks who become eligible for Medicare, but who may want to delay their Medicare enrollment because two things are true: because they are actively working, or their spouse is actively working, and they have employer-based coverage based on their active employment or their spouse's active employment. So those two things are true. Folks can delay their Medicare enrollment, and then they could apply into Medicare or enroll into Medicare using the special enrollment period, or the SEP. Using the SEP will prevent that person from being liable to a Part Medicare late enrollment penalty. And again, we'll go in depth about the general enrollment period and the special enrollment period at tomorrow's Maximizing Access to Medicare training.
Gia?
Yes.
So we are able to see two slides, like we see your current slide, then we see the next slide with your notes under it. Is there a way to...
Oh, okay. Let's see.
I don't know how you see it on your end.
Yeah, I have two screens, which may be.
Oh, okay. If this, you can keep it like this if it's not a problem, but...
Let's see if I. No, I don't think that's gonna do it.
I wasn't sure if
Display
it was
settings.
intentional, so I just wanted to make sure that you knew.
Yeah, I was seeing. I have two screens. One screen is the one that you're talking about. The other screen I have is a full screen. So I was under the impression that folks were watching the full screen one. But let me see if I could tweak that. Is that?
Oh, yeah, there you go. Perfect.
Okay. Cool.
Thank you.
No problem. Sorry about that. Okay. So qualifying for premium free Part A. As we talked about it, Medicare is an alphabet soup. Has different parts, Part A and Part B. Part A is free for most Medicare eligible beneficiaries. In fact, I think the data indicates that 99% of Medicare beneficiaries are eligible for premium-free Part A, meaning that they don't have to pay a monthly premium for Part A. And they're eligible for free Part A because they have at least 40 calendar quarters or 10 years of work history in any job where they paid Social Security taxes in the United States, or are eligible for railroad retirement benefits, or have a spouse that also qualifies for premium free Part A under 1 or 2. So again, 99% of Medicare beneficiaries who become Medicare eligible are eligible for free Part A. Beneficiaries who are Medicare eligible but do not meet any of the criteria above, however, must pay a Part A monthly premium. And we'll talk about what the Part A monthly premium is at a later slide. So this is again reiterating the Part B special enrollment period. There's two criteria for individuals to be eligible for Part B SEP. One is that they must have insurance from a current work, their job, their spouse's job, or sometimes a family member's job. And this is for people who are under the age of 65 and eligible due to disability. That's when they are sometimes able to use a family member's job status for this SEP. Or have had such insurance within the past 8 months. And two, must have been continuously covered since becoming eligible for Medicare, including the month that they become eligible for Medicare. So no SEP will be provided even if the individual has more than 8 consecutive months without coverage from either Medicare or a job-based insurance. So again, in a nutshell, the Part B SEP is accessible if somebody is either working or they have a spouse who's working and they have at the same time employer-based coverage based on that active employment or their spouse's active employment, and also 8 consecutive months did not pass that they either had this active employer coverage or Part B of Medicare. So if more than 8 months passes by, then they wouldn't be eligible for this Part B SEP. But again, we'll go in depth on the Part B SEP tomorrow's maximizing access to Medicare training. So now we'll cover Medicare coverage and costs. So Part A coverage, it covers inpatient hospital care. Again, this is coverage for folks who have been formally admitted into the hospital by a hospital doctor with admission authority. It also covers inpatient skilled nursing facility care or SNF care. A beneficiary must have spent 3 nights at a hospital as an inpatient in order to have SNF care coverage under the Part A benefit of Medicare. Part A also covers home health care. Beneficiary must be considered homebound and in need of some kind of skilled level of care. And a doctor must approve and services must be received from a Medicare certified home health agency. And finally, Part A also covers hospice care, which is comprehensive care for people who are terminally ill. The Part A costs, as we mentioned before, most people are eligible for premium-free Part A. About 99% of Medicare beneficiaries are eligible for that. So it's free for them if they have 10 years of Social Security work history. However, if they don't have that 10 years of work history, by the time they age into Medicare, by the time they turn 65, then they have to pay a monthly Part A premium. That monthly Part A premium gets pretty expensive. It's $252 if a beneficiary or a spouse worked and paid Medicare taxes for 7.5 to 10 years. However, if they have less than 7.5 years of work history, then their Part A premium is $458 a month. That's an astronomical amount. And we'll learn at tomorrow's Part 2 training of the Medicare overview, when we'll go over low-income benefits, and we'll specifically talk about one benefit that can help pay the Part A premium. So it can help pay this $458 premium or $252 premium if somebody's not eligible for free Part A. Another Part A cost is obviously the hospital deductible, which is $1,408 for each benefit period. So what is a benefit period? Benefit period is really the way that original Medicare program measures a beneficiary's use of inpatient hospital and skilled nursing facility services. It begins the day the beneficiary enters a hospital or a SNF and ends when the beneficiary has not received inpatient hospital or Medicare covered skilled care in a SNF for 60 days in a row, for 60 consecutive days. So the benefit period is not tied to any calendar year. It's really determined based on whether a person has been out of hospital, out of a SNF for 60 consecutive days. Once those 60 consecutive days have passed, that they haven't been in either a hospital or a SNF, then that will trigger a new benefit period to begin. So again, if you go into the hospital or SNF after one benefit period has ended, more than 60 days after the person has left, then a new benefit period begins. There's no limit to the number of benefit periods that a person can have or how long a benefit period can be. The hospital co-insurance is $352 per day for days 61 to 90 for each benefit period. So again, within one benefit period, it's $352 per day. It's $750 per day co-insurance for days 91 to 150. And these are the 60 non-renewable lifetime reserve days, meaning that you cannot renew those days. These 60 days can be used only once, and the beneficiary will pay co-insurances for each one, $704 in 2020. To better understand the lifetime reserve days, let's try to imagine an individual who had a 120-day Medicare covered inpatient stay, meaning they used 30 lifetime reserve days. So after they have been out of the hospital for 60 days in a row, they will be eligible for another 90 days of hospital coverage because they will be in a new benefit period. However, if they need inpatient care beyond the benefit period maximum, which is 90 days, they will only have 30 days of their 60 lifetime reserve days because they had already used 30 days in their previous benefit period of those lifetime reserve days. So it's really these 60 days that the Medicare program provides to Medicare beneficiaries that are non-renewable. Finally, Medicare covers skilled nursing facility care. It's free to stay at a SNF for the first 20 days, but days 21 to 100 per benefit period carry with it a $176 co-insurance per day. Part B coverage. So Part B coverage is outpatient coverage. So it's care provided to a beneficiary by healthcare professionals if beneficiary was not formally admitted as an hospital inpatient. So when does that usually come into play? If somebody, let's say, is picked up by an ambulance and is rushed to the hospital, but they're at the emergency room, or somebody walks into the hospital and they're in the emergency room and they haven't yet been admitted as an inpatient, well, even though they're in a hospital setting, because they haven't yet been admitted as an inpatient, they're under an outpatient category, which means that Part B is actually covering that emergency room visit because they haven't been admitted as an inpatient. Once they get admitted as an inpatient, then that's when Part A kicks in and will start covering their stay. Part B also covers doctor services, so medically necessary services provided to a beneficiary by a doctor. That means if somebody goes to a doctor's office or a specialist's office, Part B is covering those services there. Preventive care. So Part B will cover preventive care services. So these are things like screenings, annual wellness visits, mammograms, pap smears, prostate cancer screenings, diabetes screenings, vaccines and immunizations. That's all under the preventive care umbrella of Part B coverage. Part B also covers home health care, which is care used to treat an illness or injury in the home. And Part B also covers durable medical equipment, which is equipment that helps a Medicare beneficiary complete their daily activities. It includes a variety of items such as walkers, wheelchairs, and oxygen tanks. And Medicare usually covers DME if the equipment is durable, meaning that it is able to withstand repeated use. It serves a medical purpose, is appropriate for use in the home, and is likely to last at a minimum of 3 years or more. So for Part B costs in 2020, the annual deductible is $198. So that's a deductible that has to be met every year before Part B actually kicks in and starts covering services. Anybody who has Part B will have to pay a Part B premium. And in 2020, that Part B monthly premium is $144.60. The way that is paid is generally that somebody collecting Social Security benefits and has Medicare Part B, Social Security will automatically deduct $144.60 from a person's Social Security benefits, either Social Security retirement or Social Security disability. That is automatically deducted by the Social Security Administration to pay the Part B premium. People with high incomes may pay more for this monthly premium, and this is the IRMA, the income-related premium amount for folks in the higher income brackets. Then Part B also carries co-insurance. So we've all heard that Medicare Part B covers only 80% of Medicare approved amount for doctor services. So a beneficiary will be liable for the 20% co-insurance. So for example, if they see a doctor and the doctor, the bill for that doctor's visit is $100, then Medicare Part B covers 80% or $80, and the beneficiary or the patient will be responsible for 20% or $20. Note that coinsurance is sometimes also called cost sharing. So coinsurance varies depending on the type of care that's received, the provider type, and the provider contract with Medicare that is in play, and the agreement provider has with Medicare. So I think this is usually a point of confusion amongst folks. So within the Medicare program, there's actually 3 contract types that providers can make with the Medicare program, with the federal government. One is the participating provider, the participating doctor, and they accept Medicare, of course, but they also accept Medicare's approved amount for healthcare services as full payment minus the coinsurance. So these are the folks that that will accept Medicare's full payment, and then we'll just charge the normal 20% coinsurance to the patient. However, there is also a non-participating provider contract. They are as much part of the Medicare program as participating providers. However, non-participating doctors can actually bill up to 15% more than Medicare's approved amount for non-participating providers. So they could bill beneficiary 15% more. However, states do have the leeway to restrict that amount, and in New York State, a non-participating provider is limited to only charging 5% more than the Medicare approved amount. So in New York State, non-participating providers can bill up to 5% more and no higher than that. Even though nationwide, non-participating providers can bill up to 15% more. And then there's the opt-out doctor. So opt-out doctors are definitely providers that Medicare beneficiaries want to try to stay clear of. And that's because these are providers who do not wish to enroll in or be part of the Medicare program. So as such, they can opt out of Medicare. And providers who wish to opt out must submit a signed affidavit to Medicare, to the federal government, confirming their decision to opt out. So that's a formal procedure that they have to take. In order to be an opt-out doctor, they have to formally sign an opt-out affidavit and submit that affidavit to the federal government, to CMS, the Centers for Medicare and Medicaid Services. Only then will that doctor be formally recognized as an opt-out provider. If they don't follow those rules, if they don't submit that affidavit and they see a Medicare beneficiary, then they can't bill that Medicare beneficiary because they haven't followed the specific guidelines in order to formally opt out of the Medicare program. If they have followed those guidelines and they formally opted out, then they do not accept Medicare for any Medicare beneficiary that walks into their doors, and they can charge that Medicare beneficiary whatever they want. But again, they have to formally follow the guidelines to officially opt out by submitting that opt-out affidavit to the federal government in order to be recognized as an official opt-out provider. So original Medicare, unfortunately, has some pretty lousy coverage of several services. In one of the, I think it was last month's training, last month's CHA training, we talked about how original Medicare really has very little coverage of dental care. It actually only covers dental care in very limited and very restrictive scenarios. For example, I think there's just a handful of scenarios where original Medicare covers dental services. One scenario is if a tooth extraction is needed because of a reconstruction of the jaw surgery. So it's very specific and very limited scenarios where original Medicare will actually cover dental services. Most vision care is also not covered under the original Medicare program. Routine hearing care, most foot care, most long-term care, alternative medicines, most care received outside of the United States. Personal care or custodial care, if there's no need for a skilled level of care, would not be covered under original Medicare. And most non-emergency transportation. Medicare Advantage plans, however, may cover some of these services, and we'll talk about Medicare Advantage plans later on. So now we'll move on to the Medicare drug coverage benefit, which is the Part D. It is outpatient prescription drug benefit for anyone with Medicare. A person is eligible to enroll into Part D plan as long as they have either Part A or Part B. So a person doesn't need both parts of Medicare in order to be eligible to enroll into a Part D plan. They need just one part of Medicare to be eligible for Part D coverage. There's two ways to get Part D coverage. If somebody has original Medicare, as we spoke about, original Medicare only has, in the original Medicare card, only has room for Part A and Part B. So anybody with original Medicare who wants Part D coverage has to enroll into a standalone Part D plan, which is a private health plan that offers Part D coverage within the Medicare program. However, if a beneficiary has a Medicare Advantage plan, usually most Medicare Advantage plans already include in the umbrella of that plan Part D coverage. So the Medicare Advantage umbrella would include Part A, Part B, and Part D coverage all wrapped up into this one plan. Everyone is responsible for a monthly premium when they have Part D coverage, and beneficiaries with low incomes, however, can get help with costs. And again, we'll talk about those low-income benefit programs at day 2 of this training. Each Medicare drug plan has its own formulary or a list of covered drugs, and it's very, very important to keep in mind that Part D plans will only cover drugs in that formulary. And again, every formulary is different. So if a beneficiary is being prescribed a drug that is not on their plan's formulary, then they won't be able to get that drug covered unless they make some kind of formulary exception. So they have to go through a process with the plan to get a non-formulary drug plan covered. And again, it's no guarantee that that will happen. So it's very important for folks to keep in mind that every formulary is different and that they should ensure to enroll into Part D plans that have most of their drugs as part of that formulary. Plans must offer at least 2 drugs under each type of drug class, and plans must also cover substantially all drugs from a few classes. So some of those classes include antipsychotics, anticonvulsants, anti-cancer drugs. Those are the drug classes where substantially all drugs should be covered by every Part D plan in existence. A few classes, however, of drugs are explicitly excluded from Medicare coverage by law. These include drugs used to treat anorexia, weight loss, or weight gain, fertility drugs, drugs used for cosmetic purposes or hair growth, drugs that are only for relief of cold or cough symptoms, prescription vitamins and minerals, drugs to treat erectile dysfunction. So these are drugs that are explicitly excluded from the Medicare program, and no Part D plan by law can cover those drugs. So each plan charges different premiums, deductibles, and copays. Again, this varies from plan to plan. Just like formularies vary from plan to plan, Part D costs vary from plan to plan. The national average premium, so the national average of Part D premiums is $32.74 in 2020. In New York State, the average Part D premium is $36.55. So the national premium, the national average is $32, but in New York State, the state average is $36.55. The national average premium, however, is used to calculate a person's Part D late enrollment penalty, which is 1% for every month that person goes without Part D coverage or credible drug coverage. So usually a person should enroll into Part D when they first become eligible for Medicare, in the same vein as somebody should enroll into Part B when they first become eligible for Medicare, unless they're working and they have employer-based coverage. Folks should enroll into Part D unless they have credible drug coverage when they first become eligible for Medicare. And if they don't, they may be liable for a Part D late enrollment penalty, which is calculated based on the national average premium of $32.74. Medication copays vary not only across plans, but they also vary within one plan, and it varies because there's different phases of coverage within every plan. And a person, no, I'm sorry, that's actually jumping the gun on that. So medication copays vary based on the tiers that those drugs are in. So tier 1 generics is probably going to be the cheapest drug for a beneficiary to get. Tier 2 preferred brand names, tier 3 non-preferred brand names, and tier 4 and above, which are specialty drugs, are the most expensive within a given plan. And again, Extra Help is a federal program that could help lower the cost of these Part D drugs. And we'll talk about Extra Help at day 2 of the training, the Medicare overview. So what I was referring to about having different costs within the same plan is because there are different phases of coverage within one Part D plan. So for example, if a Part D plan has implemented a deductible, not all plans will implement a deductible, but there are many plans out there that have a Part D deductible. That Part D deductible must be met by the beneficiary before Part D coverage actually kicks in. So at the deductible phase, if the plan does have a deductible, the beneficiary will actually have to pay the full cost of their drug, the 100% of the cost, until they meet that deductible. While deductibles can vary from plan to plan, no plan deductible in 2020 can be more than $435. So the deductible limit is set by the federal government. In 2020, it's $435. Again, plans may set a deductible that is less than $435. Some plans may set it at the maximum of $435, but they cannot set the deductible more than that. And again, during the deductible period, the beneficiary will pay 100% of the cost until they reach that deductible amount. Once they meet that deductible, they will move into the initial coverage period. This begins after the beneficiary meets the deductible, and during this period, generally the plan will cover the bulk of the drug cost. So the beneficiary will pay a portion of the cost of their drugs, the coinsurance or the copayment of their drug, which again varies by plan. How long a person remains in this initial coverage period depends on their out-of-pocket drug costs and their plan's benefit structure. And most plans' initial coverage period ends after a beneficiary has accumulated $4,020 in total drug costs in 2020. So once they've reached that amount, that threshold, $4,020 in 2020, then that's when they move from the initial coverage period to what we know as the coverage gap, which we also know as the donut hole. So after a person's total drug cost reaches $4,020 in 2020, the beneficiary will move from the initial coverage period and into the coverage gap. So during the coverage gap, the Part D plan unfortunately takes a little hiatus, a little vacation. It really has no involvement in the coverage gap. Thankfully, due to the Affordable Care Act, which was passed in 2010, the donut hole or the coverage gap has been closing since 2011. Before the ACA, when somebody found themselves in the coverage gap, they would be required to pay 100% of the cost of their drugs because the Part D plan took a little vacation during that gap, so they were required to pay 100% of the cost. But again, since the ACA has been closing the coverage gap, it has closed since 2011 until 2020 when the coverage gap was officially closed. Now, that doesn't mean that a person is going to not pay anything for their drugs during the coverage gap. What the closure of the coverage gap means is that beneficiaries will now get a substantial assistance in paying the cost of their drugs during the coverage gap. And the next slide we'll see, here it is, we'll see how the closure of the coverage gap has occurred since 2017. Again, it's been closing since 2011, but I just wanted to provide a little snapshot of the most recent years of how they've closed. So in 2017, a person would pay 40% for brand name drugs instead of 100%, and a person will pay 51% for generic drugs. In 2018, a person will pay 35% for brand name drugs and 44% for their generic drugs. In 2019, a person would pay 25% for brand name drugs and 37% for generic drugs. And in 2020, that coverage gap has officially been closed, and a person shouldn't pay more than 25% for either their brand names or their generic drugs. So that is what the closure of the coverage gap means. Doesn't mean that every drug during the coverage gap is going to be 100% covered, but as opposed to how it used to function, where a person would have to pay 100% of the cost of their brand names and their generic drugs, it is light years ahead of that. Thanks to the Affordable Care Act, now folks will only pay 25% for brand names or 25% for generics. So once they're in the coverage gap and they're paying that 25% for brand or generics, after spending $6,350 out of pocket in 2020, a person then reaches the next phase of coverage, and it moves them from the coverage gap to catastrophic coverage. So the out-of-pocket costs that are included in tallying up the total to move from the coverage gap phase to the catastrophic coverage phase includes the deductible, the co-pays that were paid during the initial coverage period, certain costs during the coverage gap, almost the entire cost of brand name drugs, and what the individual spent on generics, 25% that they paid. Certain drugs costs paid by others, family members, charities, or the state pharmaceutical assistance programs like EPIC in New York State. Those will also be included in tallying up the total to reach that threshold to move from the coverage gap phase to the catastrophic coverage phase. Under catastrophic coverage, once a person reaches that catastrophic coverage phase in 2020, beneficiaries pay only 5% of the cost of their drugs, or they pay $3.80 for generics or $8.95 for brand names, whichever of those two are greater. So if it's either the 5% or the set co-payments for brand and generics, whichever is greater, that's the amount that they will pay during catastrophic coverage. So that's when the Part D plan comes back from their vacation during the coverage gap, and they will substantially pay the bulk of the cost of a person's drug costs. Part D enrollment. So beneficiaries can enroll into Part D plan during their initial enrollment period, enrolling during the first 3 months of the IEP, which is again advisable for when folks should first enroll into Medicare, because then their Medicare effective date will be the first of the month of their 65th birthday month. If they enroll during the IEP, into a Part D plan as well during the IEP, then their Part D coverage will also begin the first of the month of their 65th birthday month. Enrolling in the month after the 3 months of their initial enrollment period means that their Part D coverage will begin the first of the following month. So again, always advisable to enroll in the 3 months prior to their 65th birthday month. Beneficiaries can also enroll or make changes to Part D coverage during what we know as a full open enrollment period. This is an annual period, begins every year in October, ends in December. This is an open period for folks to choose to change the Part D plans, to change the Medicare Advantage plans, but it's also used if somebody missed their initial window to enroll into Part D, they can use the full open enrollment period to enroll into Part D for the very first time. However, because they missed their initial window, if they enroll into Part D for the first time during this open enrollment period, they may likely incur a Part D late enrollment penalty. If eligible, beneficiaries can use various special enrollment periods or SEPs available under certain situations. For example, if they change addresses, if they move, then they can get that special enrollment period that's applicable for individuals who change addresses. So now we're going to Medigaps, and I see we actually have only 10 minutes. Where did the time go? My goodness. Okay, so Medigaps are supplemental insurances that can help pay the cost sharing associated with original Medicare. Medigaps are private health insurance policies people with original Medicare can buy to fill the gaps in Medicare coverage. So the gaps that I'm talking about are the cost that we mentioned during the cost section of this training, the 20% co-insurance for Part B that original Medicare doesn't pay for, the co-payments for hospital inpatient stays or SNF inpatient stays. Those are the gaps in coverage that I'm referring to. Medicare premiums in New York State range from around $100 to almost $300 a month. And there are 10 standardized plans, alphabeticalized, A, B, C, D, F, G, K, L, M, and N. So within Medigaps, several benefits that are included, and this is not an all-encompassing list, but they include hospital co-insurances, so they pay the hospital co-insurances that we mentioned in the beginning of this training. Also, Medigaps provide 365 days of full hospital coverage on top of the Medicare covered days. So that's many more days in addition to the 60 lifetime reserve days that we had discussed earlier on. Medigaps can also cover full or partial coverage of Part B co-insurances and co-pays. It could also cover full or partial coverage for the first 3 pints of blood needed each year, and can also cover hospice care co-pays for respite services. Okay, now going into Medicare Advantage plans. So I want to give everybody a visual kind of cue between the differences of original Medicare and Medicare Advantage plan, because even though both forms of coverage are under the Medicare program, they are very different from one another. Under original Medicare, a person can see any original Medicare doctor that accepts original Medicare in the country. So original Medicare folks are not constricted to a network of providers. A person with original Medicare in the state of New York, if let's say they spend 3 months of the year every year in Florida, they could see any provider in Florida that accepts original Medicare, again, without being constrained to a network of providers. So anybody that accepts Medicare can see an original Medicare beneficiary across the country. However, one of the main differences with Medicare Advantage folks is that Medicare Advantage will usually restrict their members to a network of doctors and facilities. So members should definitely always keep in mind when seeing a doctor, when going to a hospital, when going to any kind of medical facility, that those providers, those facilities are within the network of their plan. With original Medicare folks, they don't need to get a referral for specialists. Medicare Advantage folks usually require referral to see a specialist, and if they don't get a referral, then they may be liable to for the full cost of that care. Under original Medicare, as we mentioned, it doesn't include comprehensive coverage for hearing, vision, or dental services. It's pretty lousy in that department. However, most Medicare Advantage plans will at least provide routine hearing, vision, and routine dental coverage. Original Medicare, however, does not limit any out-of-pocket costs, unlike Medicare Advantage plans. So all Medicare Advantage plans must set what's called an annual limit on their out-of-pocket costs, and this is known as the maximum out-of-pocket limit, the MOOP. In 2020, the MOOP for Medicare Advantage plans is set by the federal government at $6,700. But plans may set their MOOP at less than that federal limit. After reaching the MOOP, the beneficiaries will not owe cost sharing for Part A and Part B services for the remainder of that year. So once a person reaches the MOOP in their Medicare Advantage plan, then the Medicare Advantage plan pretty much covers 100% of their Part A and Part B services during that calendar year. Because original Medicare folks don't have that option, however, they do have one option that Medicare Advantage folks do not have, and that is the option to enroll into a Medigap plan, which again supplements the gaps in original Medicare's coverage. So Medicare Advantage costs may cover additional services that original Medicare does not cover, and for that reason, many Medicare Advantage plans may charge an additional premium on top of the Part B premium because it's essentially them saying this is the premium that we're charging you for these additional things that we're covering that original Medicare doesn't cover. But every plan is different. Every Medicare Advantage plan can set their deductibles, co-payments, and co-insurance structures that vary amongst plans. And all plans must have a maximum out-of-pocket limit, or the MOOP that we just discussed. And again, that MOOP limit is set by the federal government, but a Medicare Advantage plan can set the MOOP limit at less than that federal limit. And again, Medicare Advantage beneficiary cannot have a Medigap. And we also discussed this, Medicare Advantage beneficiaries are constrained to a network of providers. So in-network providers means that that provider contracts with that Medicare Advantage plan to provide healthcare services. Out-of-network providers do not contract with the plan, and therefore if a Medicare Advantage member sees an out-of-network provider, they may be liable for the full cost, 100% of the cost rendered at that out-of-network provider or that out-of-network facility. Certain plans may offer coverage for out-of-network services. So some Medicare Advantage plans are PPO plans, and in these cases, the beneficiary is normally responsible for a larger portion of the cost sharing if they see out-of-network providers, but they at least won't be responsible for the 100% of the cost. Medicare Advantage special needs plans are Medicare Advantage products that are designed to meet specific care needs. The network in special needs plans, or SNPs as we like to call them, includes doctors who treat specific conditions. Formulary includes drugs used for those specific conditions, and also provides case management and coordination programs. Plans must include prescription drug coverage in every SNP plan. And again, those prescription drug formularies are catered to the specific SNP plan that a person may be looking at. So there's three types of SNPs, or special needs plans. There's the chronic condition SNPs, plans for individuals with chronic conditions. There's the institutional SNPs, or plans for individuals who live in an institution. And then there's the dual eligible SNPs, which are SNPs for dually eligible individuals. These are for individuals who have both Medicare and also Medicaid. Supplemental benefits. So supplemental benefits within Medicare Advantage plans generally have to be primarily health related. However, that has been ever changing under the current administration. In 2019, the definition of primarily health related was expanded. So Medicare Advantage plans can cover more supplemental benefits than they used to. And in 2020, supplemental benefits for plan enrollees with chronic conditions actually do not have to be primarily health related at all. These are known as special supplemental benefits for the chronically ill, or SSBCIs. And such benefits can include things like Meals on Wheels, things like pest control, which are not specifically coinciding with medical or primarily health related supplemental benefit. So again, that definition has been expanding, and plans have a little bit more leeway in providing these supplemental benefits to try to lure beneficiaries to their plan. So people with Medicare Advantage plans do have some beneficiary or many beneficiary protections, enrollment and coverage rights. These are enforced through appeals and grievances. So a person, if they're denied coverage by a Medicare Advantage plan for a certain service, they have a right to appeal. They have 5 levels of appeal. They could appeal. The first level would be appealing that denial with the plan, and that the plan upholds their denial. Then they could appeal to the independent review entity, and they could go on to the Office of Medicare Hearing and Appeals, and move on to the Medicare Appeals Council, and finally the last level of appeal would be federal district court. They could also file grievances with the plan if they don't like how the plan is handling their appeal. They don't like the customer service they've received from the plan representatives. They could file a grievance, and they could file a formal grievance with the plan, and also they should want to file a grievance against the plan with 1-800-Medicare. So 1-800-Medicare is administered by the CMS, the Centers for Medicare and Medicaid Services. So they keep tabs on these grievances that folks make about their plans. Beneficiaries also have a right to information about plan payment of providers. Medicare Advantage plans cannot deny enrollment based on prior claims experience, medical history, or genetic information. They must offer cost-sharing structures to encourage they cannot offer cost-sharing structures to encourage or discourage enrollment. They cannot promote discrimination or inhibit access to services, and they cannot charge different cost-sharing for different regions with same plan area. Beneficiaries also will have or are required to get emergency services covered by a Medicare Advantage plan, by the Medicare Advantage plan. So, as we spoke about, usually a person who sees an out-of-network provider and within their Medicare Advantage plan, they see a provider that is outside of that plan's network, they're liable for the full cost of those services. However, in emergency situations, if they see out-of-network providers because of an emergency situation, the Medicare Advantage plan is required by law to provide coverage to that emergency service that it was rendered at an out-of-network provider. And also, if they see a provider without prior authorization under emergency conditions, then that Medicare Advantage plan cannot require that prior authorization because of that emergency. Also, if CMS terminates a Medicare Advantage plan, a beneficiary will get a special enrollment period, or SEP, to enroll into a new plan. And that SEP begins 2 months before the coverage ends, and it lasts up to 1 month after the contract ends. Okay, so we've reached 11, back to a minute over 11. We just have a few more slides to cover Medicare and coronavirus. Is that fine, Catherine?
Yeah, can everyone let me know in the questions tab if you are able to stay on, or if this is okay? I guess if you aren't able to stay on, feel free to leave. We will have a recording on the portal, but if you can stay on, or if you have any questions, that'd be great.
Great.
So I see a few people saying that, yes, they'll be able to stay.
Cool. Great. Thank you, everybody. Sorry for going a bit over, but yeah, these are just the last few slides, and I wanted to talk about, all the slides prior to this is how Medicare has functioned, and all the regulations and all the rules that have been in place. Obviously, the COVID-19 pandemic has kind of upended the entire system. So I'm going to talk about in these few slides some of the temporary regulatory changes that have been made to make Medicare coverage during this crisis more streamlined and more easily accessible to beneficiaries. But again, many of these may be, we don't know for a fact which of these changes are going to stay in place even after the pandemic, or which are going to go away. So for now, we're just going to consider these temporary regulatory coverage changes. So please keep that in mind. So for telehealth services, Medicare generally only covers telehealth in limited situations for certain beneficiaries, but it has expanded coverage and access during this public health emergency, COVID-19 emergency period. So during the public health emergency, telehealth services are covered under Part B for all beneficiaries throughout the country in healthcare settings and at home. Examples of covered services include hospital and doctor's visits, behavioral health counseling, preventive health screenings, home health care services when listed on plan of care. Before the public health emergency, it used to be that only a very limited number of providers can provide telehealth services, but that has been expanded. The list of providers have been expanded during this public health emergency, will include doctors, nurse practitioners, clinical psychologists, and licensed clinical social workers that can provide telehealth services and still be covered under the Medicare program. Standard cost sharing may apply, but CMS, the Centers for Medicare and Medicaid Services, has strongly encouraged providers to waive cost sharing of telehealth services. So, but that's up to the discretion of the provider, but it has been strongly encouraged to waive these services during this public health emergency. Skilled nursing facility care. So Medicare has actually waived some SNF coverage requirements. And as we just spoke about in the beginning of this training, Medicare usually requires a beneficiary to have spent 3 days in the hospital as an inpatient before Part A covers SNF care. However, during the emergency period, Medicare has removed this 3-day qualifying hospital stay requirement for beneficiaries who experience dislocations related to the public health emergency. It includes, but is not limited to, beneficiaries who need to be transferred to a SNF, for example, due to nursing home evacuations or to make room at local hospitals, or need SNF care as a result of the current public health emergency, regardless of whether they were previously in the hospital. So again, this waiver of the 3-day hospital stay requirement for SNF coverage has really helped folks get SNF coverage in a more streamlined fashion without having to go through that requirement as they were required to do so prior to the public health emergency. So the benefit period has also been changed. So Part A typically covers up to 100 days of SNF care each benefit period, and we discussed what the benefit period is. It begins when a beneficiary is admitted to a hospital as an inpatient or to a SNF, and it ends when they have been out of the SNF or a hospital for at least 60 consecutive days. The 100 days of covered SNF care will reset at the beginning of a new benefit period. However, beneficiaries who are unable to start a new benefit period because of the public health emergency can get another 100 days of covered SNF care without having to begin a new benefit period. So they don't have to be out of a SNF for 60 consecutive days to begin a new benefit period. Due to this public health emergency, if their circumstances require them to stay on a SNF longer than the 100 days, then they don't have to meet a new benefit period to get another 100 days covered. So that's a huge regulatory waiver that was provided. Home health care changes under COVID-19. So Medicare has changed some home health care coverage requirements. The homebound requirement can be met in additional ways. Someone can be considered homebound if their physician certifies that they should not leave their home because of COVID-19 related circumstances. Maybe they have a medical condition that makes them susceptible to contracting COVID-19, or if they have a suspected or confirmed case of COVID-19. So these are other avenues to getting home health care during this public health emergency. During the public health emergency, the federal government, CMS, has required Medicare Advantage plans to do several things. Medicare Advantage plans and Part D plans must cover up to 90-day supplies or length of the prescription, whichever is shorter, of prescription at beneficiaries' request. So a plan cannot put quantity limits on drugs that would prevent beneficiaries from getting the full 90-day supply as long as the beneficiary has prescription for that amount. The exception to this, of course, is things such as opioids that have safety edits restricting refill amounts. Also, plans are required to cover formulary Part D drugs filled at out-of-network pharmacies. So Part D plans must do this when a beneficiary cannot be expected to get covered Part D drugs at an in-network pharmacy. Some optional plan actions that plans can take is that they could relax restrictions on home delivery and refilling prescriptions too soon. If a beneficiary wants to refill a prescription early, they should contact the plan. So these are optional actions that CMS has allowed plans to take. Again, not every plan is required to take these actions, but these are optional and is being encouraged by CMS. And finally, cost sharing changes. During the public health emergency, there's no cost sharing for coronavirus testing and associated visits. So that has been waived under the public health emergency. And this applies to either somebody in original Medicare or Medicare Advantage plan. Whatever Medicare coverage that they have, they should not face any cost sharing for coronavirus testing and associated visits. Providers can also waive cost sharing for telehealth services. Again, that is being strongly encouraged. Provider gets paid Medicare approved amount for service and does not charge a beneficiary for co-insurance or co-payment if they want to waive that cost sharing. It's generally not allowed as a blanket policy due to anti-kickback rules. So that's why it's not just a blanket policy. It's just being strongly encouraged. MA plans have the flexibility to waive cost sharing for other services related to coronavirus, and a beneficiary should contact their plans for specific details. And another thing to add that's not on this slide is that Part B will cover 100% of the hopefully soon COVID-19 vaccine that will eventually make its way. So once that is created, Part B will cover that vaccine 100% under its preventive screening coverage category. Okay, and that wraps up day one of the Medicare overview. Thanks everybody for sticking around even after the time limit was passed. And now I could definitely take any questions that folks have.
Thanks, Gio. So I see a hand raised. Melissa, I'm going to unmute you. Melissa?
Yes.
Hi.
Hi. What happened?
Oh, you had your hand raised, so I assumed
I don't know. I'm not even touching my computer. That is really weird.
Okay, no problem.
No
Sorry
worries.
about that.
No worries.
No worries. Any questions? I'm looking at the questions tab and seeing if there are other hands raised. I'll give people a minute to type in any questions. Great. No questions? No hands raised?
I know that was a lot to kind of take in an hour and 10 minutes. So it may take some time for it to like rest and maybe digest. So yeah, I'm always if there's no questions now, I'm always happy to be reached for any questions. So Catherine, if anybody asks any questions, feel free to forward them on to me.
Sure. Oh, actually, there is one question I'm going to unmute. Kenny?
Hi, Gio. I'm just wondering, do you guys know what's the processing time for Medicare enrollment at this during the pandemic?
For Medicare enrollment?
Yes.
There's no set processing time, but there are a few things that are obviously affecting processing time. Social Security field offices are still closed. Many Social Security staff are working remotely. However, at the same time, and that may negatively impact the processing time. At the same time, we have heard from our Social Security regional contacts that they're making a great effort to try to try to streamline the Medicare enrollment processing timeframe as best they can. But usually, I would say, from my experiences, it should take 4 weeks, perhaps, for that enrollment processing to take place.
I see. Because I know even before the COVID-19 thing, even calling Social Security office sometimes could take a long time. I'm wondering if they actually increased the staff on receiving calls during this time.
Oh, at the Social Security office. I mean, I don't have the data, but I'm sure that the Social Security helpline number, the national number, has been inundated with calls, and that's because all the field offices have been closed. So right now, the only alternative to get into contact with Social Security to make any kind of request through Social Security is either online, if somebody's savvy enough to enroll into Medicare using the Social Security online portal. But if they're not, then the other alternative is to call that national helpline. So I could imagine how Social Security has been inundated with calls.
I see. All right. Thanks for the updates.
Problem.
Great, thanks, Kenny.
And I do just also want to say, if you do have any specific clients that maybe they've been waiting far too long for Medicare enrollment processing, we do have a contact. We do have contact with the New York Regional Social Security Office that helps us out on several cases. So we're always happy to take any warm transfers or any case referrals that you may have of any clients who are finding it difficult to enroll into Medicare at this time.
Right, and then Krista Navakid added that she had a client who at the end of May had to pick up Medicare Part B due to retirement and losing coverage, and they already received their effective dates for Part B. She had them call. So.
Oh, great, and that was the end of May.
Mm-hmm.
Oh, great. Okay, great. Yeah, so from at least during this COVID-19 pandemic, of the cases that I've seen firsthand, I've seen quick turnarounds like the one that Krista brought up. I've also seen some that have taken far too long, and then we've had to reach out to our regional contacts. So I can't say for sure which one is the norm, but we have seen a variety of different timelines come to our doorstep.
Great. Great. So Gio will be joining us tomorrow again for the second part of this training. So thank you, Gio, for the first part. And if
No problem.
I see, sorry, Gio. I mean, can you take 2 more questions?
Sure, of course. Yeah.
Okay. So someone asked, whose email can we use to provide case? Oh, I can provide you with that. Gio, I'm assuming we can provide your email if
Yes.
clients are having a hard time enrolling.
Yes, for sure. Yes, my email will be the best way to alert Medicare rights that you want to either refer a client regarding that specific issue.
Great. And I guess that answers the second question as well. Is MRC still helping people with reinstating Medicare with Part B enrollment and conditional Part A?
Oh yes, very much so. Because of the fact that Social Security offices have been closed during the emergency period, folks who want conditional Part A, they will need to call to make that request over the phone. Social Security should take that request over the phone. Obviously, we know from experience that even if somebody goes in person to their Social Security office, that they still may run into issues in person when they bring out the printouts or the handouts of the policies for the conditional Part A enrollment. So we could imagine, the barriers that somebody may face when they're actually calling and talking to somebody over the phone at Social Security to try to enroll into conditional Part A. But this is something that very much so can be done and should be done over the phone. But again, if there's any issues, if somebody's calling Social Security office trying to make a conditional Part A enrollment and the Social Security representative they're talking to is saying, I have no idea what you're talking about, so I can't do this over the phone, that is at that point you could reach out to me, and then we could bring the case to the to our regional contacts.
Yeah, great. And I'll, in the follow-up email, I'll provide Gio's email information. So yes, thank you
Cool.
so much, Gio.
No problem, Kat. Thanks for setting it all up and for guiding me into what's what here.
Yeah, no problem. So that completes the AM session, and we will see the rest of you during the PM session. Thank you so much.
Have a great rest of the day, everybody else. I'll talk to you tomorrow.
Bye, Gio. Bye, everyone.